We're very happy to welcome Corinne Hohl. My job is to introduce her, but she really kind of goes without introduction. She's a researcher, an emergency room physician, an absolute ball of fire. She has made some very remarkable things happen in British Columbia. Her motto, I think, if I can remember correctly, is the easiest ADR is not the first one, it's the second one. And I think today we'll discover why that might be her motto. We now have a system in place where adverse drug events are being tracked and recorded in patient records in hospitals in British Columbia, which is a real major innovation. And I'm going to pass it over to Corinne to fill us with her wisdom.
Hi, everybody. I'm just gonna. Thanks, Alan. Thanks, Aaron. Can you guys see my slides?
Yes, we can. Perfect.
Okay, thanks, guys. I apologize if you hear background noise. My kid is not off to school yet. He's in this weird, not quite back to school yet mode. So I'm gonna try to give you a bit of a rundown of the work I've been doing. It's really the culmination of a bunch of work that stems from just clinical epidemiology work that I have done over the past decades together with collaborators and colleagues. I just wanted to acknowledge that I'm on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And very much just appreciate that I can work and live in this area. What I'm going to try to do is first talk a little bit about the background about how I, as an emergency physician, got interested in this area. A lot of people, when they learn that I'm an emergency physician, they kind of come up to me and they go, Corinne, why on earth do you work on adverse drug events? In our minds, we've often relegated adverse drug events to, internal medicine or their prevention to our family medicine colleagues, possibly pharmacologists for really complex cases. And one of the things that happened to me, vicariously or not, when I was a medical student was I just was seeing a lot of patients whose medication lists I did not understand, and they were far too long for my liking. And at some point, I, as a trainee, started realizing that most of my patients have no idea why they are on the medications that they are on in clinical practice. It may well have been explained to them, but by the time they come see me with an acute and unexpected problem, oftentimes they don't really remember. It's only the patients with the most health literacy that actually do. And then when you actually go digging as to why they come to the emergency department with a medical problem, delirium is one of the most common presentations. Oftentimes, we don't really like to dig through the medications, but when you actually do, you realize that medications are very, very important, even in a specialty that likes to talk about resuscitation science and COVID and other types of things. So that's my disclosure as to how I got interested in this field. One of the things that we as a team really started trying to understand is what is the incidence of preventable adverse drug reactions in Canadian acute care hospitals. And the reason we got interested in this is because you will read a lot about medical errors and medication errors in the literature on adverse drug reactions. And one of the things that we had always gone back and looked at was just the incidence of patients that are hitting the front door of the emergency departments that come in and we identify a drug-related cause that either is a cause or contributes very strongly to the presentation. So we had already done 3 prospective studies, 1 retrospective studies in 3 provinces. And these is just some of the data from these cohorts. As you can see, there are pretty substantial numbers of patients that were included in each of these cohorts. And one of the things we were really interested in understanding is the preventability within that. It's one thing to document that there's a problem, but it's, as a clinician, much more interesting to me to understand their preventability. Once I understand if something is preventable, I can start thinking of system solutions to try and identify how I could do better in the future. And that's really the goal of this. So what we did when we tackled this problem for Health Canada is we actually looked at these large observational studies that we had from these 5 sites. And they used very similar case definitions and enrollment methods. So we felt quite comfortable actually just pooling those data. And this is just some of the baseline characteristics of the patients who often present with one or more adverse drug events. And what we did is we did a bit of a methodological foray into how to define preventability, and we looked at the algorithms in the literature. And as you can see, a lot of the patients here, there's a fair proportion that are quite older, but not all patients are older. And the common comorbidities that you would think would be associated with this patient population are certainly prevalent in these. One of the things that we found is, regardless of how we defined preventability, whether we took a very algorithmic approach to defining preventability, or whether we just used the gestalt of two clinicians from two different clinical areas, approximately 75% of events across the board were deemed preventable. And one of the things that was very, very striking, that we had already seen, the pharmacists that were working on our research program had kind of already identified this as an issue, was that we found a lot of patients where, when you actually went back into their histories, you could actually see that they had previously come to the emergency department and possibly been admitted with an adverse drug event that was a repeat event. In other words, I'll just give you a couple scenarios. This might have been a person who came to my hospital with angioedema, and when you actually dug back and you took a good medication history, that patient actually had presented to Mount St. Joe's or one of the other surrounding emergency departments with facial and tongue swelling. And interestingly enough, the patient was just on a different ACE inhibitor than he had been restarted on the week before coming to my shop. So when we looked at that type of preventability, a high proportion of adverse drug events that were hitting our front door were repeat events. And a lot of these, particularly of the repeat ones, were deemed highly preventable. Renal failure and patients with mental health diagnoses were also associated with presenting with repeat events. And one of the things that I should disclose is, when we think about adverse drug events, we very much think about them the way a clinical pharmacist would. So we think very much around drug-related causality and harms. And so we also include non-adherence in that definition. And non-adherence tends to be quite tightly related to mental health diagnoses. So when looking at these preventable adverse drug events, these are the common culprit drug classes. When I speak about this, everybody wants to talk about drug interactions. And I keep having to tell people, when you look at large case series of clinically significant adverse drug events that hit our front door, it's actually not at all about drug interactions. Those make up about 1% of all the clinically significant events. The vast majority of these are plain old simple adverse drug reactions to drugs that we very commonly use. Warfarin, the thiazide diuretics, you can see what the common ones were in this case series. So a lot of things that we very much prescribe all the time. So this was the conclusion of the study that we did for Health Canada, and effectively the nuts and bolts of this is that if you look at errors or medication errors, which as a society, and particularly here in the Lower Mainland, we've had a very, very large, complex and expensive electronic medical record implementation ongoing now for years. That's really one of their top priorities, is to reduce adverse events and medication errors. And the interesting thing about this is, when you look at the patient population that comes into an acute care hospital, and you get adverse events outside of acute care that come in, if you look at medication errors, they are a very, very small proportion of what causes clinically significant adverse drug events. If you compare repeat adverse drug events and you look at the whole population, repeat adverse drug events are 100-fold more common than medication errors. And this holds true for all of the multi-center studies that we have done. I remember presenting this to one of our CMIOs, and he sort of looked at me and said, "Corinne, why didn't you tell me that 10 years ago?" And I sort of said, "Well, I'm sorry, the research just hadn't been done." So we've had this real focus on error prevention, and it's high time that we move away from error prevention, or that we broaden that conceptual framework of what an error is, and we move it along to something that is supported by the clinical epidemiology of how these events, or even just the frequency of these types of events. So I've already told you about my angioedema case. any clinician will tell you cases. A lot of these can, have to do with recurrent deliriums, recurrent falls, recurrent syncopal episodes, recurrent episodes of bradycardia, recurrent episodes of hypoglycemia, you name it, they come. So the big question we asked our team first was why? And one of the things that I learned in the last couple of years is to really reach out to my more qualitatively minded colleagues and not just try to stay in my quantitative world of medicine and quantitative research. And I work closely with Alan Balka, who's a qualitative researcher in communications at SFU. One of the things that our pharmacists had noted and that we were subsequently able to sort of tease out with qualitative methods was the whole why question. As I alluded to before, when a patient has an acute and unexpected medical problem, they come see me in the emergency department. They generally don't come with scheduled visits unless the scheduled visit is for, a second dose of intravenous antibiotics because yesterday they were diagnosed with an extensive infection that needs more than just PO antibiotics. So if a patient is started on a new drug and the reaction is mild, generally they might go see their pharmacist or outpatient physician, but that it's usually not done very urgently. If a patient has an acute and serious adverse drug events, which are really the ones we're worried about, they generally go to an emergency department. And one of the first things we do in an emergency department is we actually pull the patient's PharmaNet record. So that's just a full record of the patient's claims in this province. It's incredibly informative for all patients. Excuse me, that was the provincial alert system and I didn't have my phone on mute, which I now have. I apologize. So we pull all of that information. It's extremely helpful for any patient who is unable to give us a history because they are delirious, for any patient who has maybe health literacy that is not optimal, who may not speak English, or simply may not have a list of their full medications on them. The reason why that record is so, it's not perfect, but it's quite reliable is because, as you probably know, pharmacists have to enter medications into the PharmaNet database for billing purposes. So they wouldn't be reimbursed for most medications unless they actually create a PharmaNet record. And that's what we leverage for clinical care purposes. So when we make now a diagnosis of angioedema, for example, in the emergency department, and confirm that, even when we make it in hospital, we generally aim to discharge our patients. But when we discharge our patients, and this is going to happen even after the advent of Cerner, most of the clinics and most of the community resources do not share the same record as we have in the emergency department. And so what generally happens is when the patient gets discharged, they may be following up in an outpatient clinic, in a rehab facility, in a long-term care facility. They may or may not have access to our discharge summary. And sometimes, a lot of times, we found that adverse drug events are not well documented in discharge summaries. So if they read them and they have them available to them and they actually read them before re-prescribing to the patient, they may know about this adverse drug event. But if that doesn't happen, they will just simply pull the patient's PharmaNet profile, which does not contain the adverse drug event record. And as you may know, a prescription that was written before a patient got hospitalized actually is still legally valid after the patient's discharged. So if they were admitted to the ICU for airway monitoring for angioedema, if that physician does not write a discontinuation order and that patient is on automated refills, that ACE inhibitor will just get refilled. So that's our system. What we started conceptualizing was a way to really close that communication loop and to try and use our wonderful community pharmacists as part of that care continuum that can really help us on a systems level prevent this type of thing from happening. But what we quickly realized is we don't have the capacity to write information into PharmaNet. And keep in mind, PharmaNet was never designed as a clinical information system. PharmaNet is a billing database, and for that, it's pretty functional. It's also quite an old system. So here we were imagining something that was really something that PharmaNet was never conceived for. But imagine if you had a system where you could enter an adverse drug event electronically using standardized terminology and add it to that PharmaNet database, you could actually almost fully close that circle of care, because any community pharmacist must access the PharmaNet database before they dispense. And this is nowadays how all of our best possible medication history forms are being populated. So that's exactly what we aimed to do. All right. As we were trying to get a little bit more funding for this and sort of dig down deeper, this is a lot of what I have shown you previously in terms of drug interactions not being a heavy part of the utilization component nor errors. And this is a lot of the data that we were able to use to really try and have some investment into this type of vision that we were envisioning. How did we design the system? A lot of electronic systems are really designed by engineers with, one or two clinician input that sort of, design a system really largely at distance from use. And a lot of those systems don't work very well for people like myself who work in the emergency department. So the work that we undertook, it's called the participatory design principle. After doing a systematic review of adverse drug event reporting systems across the world, first we made sure the system we were envisioning didn't already exist. And then what we did, and this is really led by my colleague, Dr. Balka, she really spearheaded this, we did what's called ethnographic work observations to try and understand, how do people work? In what sequence would they actually start thinking, would they start collecting information to start making an adverse drug event diagnosis? So we really wanted to understand clinical workflow, because if you don't design an electronic system to mirror the clinical workflow, your healthcare providers are going to have to change their workflow, which is always something that's difficult to do. And then what we did after we identified clinical workflow is we engaged with clinicians, and we spent CITR money buying pizza to actually get them to sit down at lunchtime and work with us through to a preliminary design. So what they did is they did a lot of sorting of different fields, and I may have a slide that I can show you later to actually show you what this looked like. And then what they did is we issued a paper-based design and we piloted it conceptually. We did a round of iterations and piloting and refinements. And then we actually engaged with a software developer who uses what's called agile design methods. In other words, we had another sort of feedback loop between pushing out the first iteration of the software and allowing people to give us feedback. So very much an iterative process to design a software. What was really interesting when we tried to engage with clinicians, one of the things we tried to ascertain is, why don't you use what's already there? Those of you who are familiar with PharmaNet may say, hey, but Corinne, the ability to write, there's adverse drug reactions field in PharmaNet. What's up with those? And for example, clinicians told us, well, I can't access them because only community pharmacists are actually currently allowed to write an adverse drug reaction into PharmaNet in free text format. So we learned that anything that's free text is not usable at all. It's replete with errors. It's often inconsistent. You have to enable data entry at the correct interface. There's no point in enabling data entry in a location of care where a patient with a serious adverse drug event would not show up to. They won't have the information. A lot of clinicians told us their workload is just too high, and they gave us a tall order. They said documentation has to be enabled within 1 minute. So I'll show you if we were able to do that or not. Anyway, so we took all of these learnings and we took all of the factors that we thought contributed to adverse drug event underreporting in all of the current platforms that we have, be it in the PSLS system for Vanessa's Law reporting, be it in the old FDA reporting system. And effectively, we considered all of these barriers when we designed ActionADE, and we developed software requirements. This was something completely new to me. Had never been taught this in medical school or in my research training. And we basically thought through how we would have to design the software and what the requirements would be of the software in order to develop something that would be user-friendly. Then we had to do the same exercise with ministry afterwards to actually integrate that software with PharmaNet. So what I'm going to do is I'm just going to see if I can show you that software, let me see, can you guys still see my screen?
Yes.
Okay, so this is the actual software. This is a test website, but if you were a clinician at VGH and you wanted to access it, you would basically go onto the intranet, you would click on the website, and you would log on with the same password as you log on at VGH. And these are all test patients. So effectively what I do at work is I come over here. When I'm seeing a patient, I can add a new patient. I add in their PHN, and what pops up is effectively a pre-populated best possible medication history form. So this pre-populates with all of the recent dispensations from PharmaNet in here, which is very much how we tend to do best possible medication histories nowadays. So I'm just going to pretend that this patient was on a combination agent, and I want to report angioedema to ramipril. And what you would do as a primary care provider is you would just hit ADE, you would hit the terminology. This is all mapping to the same coding system that the European pharmacovigilance community uses and that pharma has to actually comply with in order to be able to run a randomized controlled trial. And then you would just basically add a couple added details that are needed by Health Canada for ADR reporting, and you would indicate the likelihood that you think that this is caused by a drug. And then I'm just going to show you what I just created. This is the report. I don't know how long it took me, but I don't think it took me a minute. And you can see that the reason why it didn't take me a minute is because we leveraged pre-population. So because it's integrated with all the ministry systems, the PHN, all the patient information is pulled into the system. It maps it to a drug that's already in PharmaNet. I could have also entered a drug if it hadn't been in there. And I'm using drop-down menus and pre-population to basically fill all of these required fields. I also didn't put in any comments. If I wanted to put in comments, I might need to spend more time. So this is the software that is now implemented in 9 acute care hospitals in Vancouver Coastal and at Providence Healthcare. And of course, when we design standalone healthcare systems, what we would not be doing is we actually, if we did that and we had stopped right there, we would not have been fulfilling the function that we really were set out to do. There's lots of standalone healthcare applications, but really the point of enabling this data entry is to get the event here into PharmaNet. So what we did in order to do that is we realized that what we would need to do is actually engage as academics and healthcare providers, not just with our health delivery organization, who needed to support us and allow us to actually change the computer systems or an application within the healthcare delivery environment, but we needed to engage with a software developer. I don't know how to program. I certainly don't know how to make something programmed look that nice and user-friendly. So we needed to have an industry partner. And then finally, we needed to engage with BC government. And that's after getting grant funding for this project, because it's difficult to put the money out for a pilot project like this. So this was very, very interesting, certainly for me, and what a qualitative researcher might call a triple helix plus configuration, because it's not just a simple triple helix of academia, industry, and government working together, but you have health delivery organizations mixing in there, you have privacy folks mixing in there, you have provincial strategies that are not quite government that are also mixing in there. And so this was a very complex endeavor to just basically get everything on the same page. So as we got funding for this, we basically went up for numerous CIHR grants, and we're very, very grateful that this work is really mostly funded by CIHR, but also in part by Vancouver Coastal and the Ministry of Health, so not-for-profit organizations. We knew we would need to have a really robust evaluation strategy for this. So what we planned and what we were able to get funding for through the Rewarding Success is we were able to plan 2 randomized controlled trials to evaluate the effect of that automated communication of medication information that goes into the PharmaNet database and then is displayed in community pharmacies. And so what we did is we basically we planned to stratify the adverse drug events going into the PharmaNet database into different types of adverse drug events. And we have a pre-planned randomized controlled trial on ADRs to understand the impact of providing that information continuity to community pharmacists in an automated manner on redispensations and health outcomes. And we have a parallel randomized controlled trial that's ongoing, looking at non-adherence and seeing whether or not, when we transmit the information around non-adherence, whether or not there's something that community pharmacists can do to try and encourage adherence behavior. So we launched both randomized controlled trials on May 7th. So we're just fresh out of the gates. And I hope that we will be able to report back on how the trials are going and how they went. And what I'll sort of, one of the things that I commonly get asked about with these randomized controlled trials is we were able to get a waiver for informed consent, which is very rare. I only found one other large randomized controlled trial that had been approved at the time I applied for ethics, that was actually approved in Canada out east to be done without consenting patients individually. So I think it's worth just spending a moment talking about that. What we don't understand in terms of the equipoise is we don't understand, for many ADRs that are non-life threatening, whether or not it is better to try and manage patients' ADRs, even if they're at risk of having recurrent events, or to actually switch them to different class drugs. So I'm just going to take an example from my work with the DSEN group. One of the DSEN investigators, Louise Pilote, has done some work using thiazide diuretics for blood pressure control agents, and found that when you discontinue thiazide diuretics, which are a very common cause of hyponatremia and adverse drug reactions in our older population, you actually may have an associated increased incidence in stroke. And so what we don't really know is, we think that if implementation of this communication may discourage redispensations of culprit medications, but we don't know if disease-related outcomes will outweigh the benefit we see from reducing adverse drug reactions. So because we had equipoise on that for non-life-threatening events, that's what allowed us to even think about doing a randomized control trial. And then in terms of the ethics, the reason we were able to get ethics approval without doing informed consent on all patients is because there's a couple reasons, but we met all of the Tri-Council policy requirements for that. It's really a randomized control trial around information exchange. We're not trying a new drug or a new medical intervention that's expected to have significant side effects on a population. We're really trying to understand the incremental effect of automating information and displaying information at the time that a redispensation of a culprit drug is about to happen, compared to the information flow that would happen normally. And we can evaluate the entire intervention in the background using administrative data sets. So by linking PharmaNet data with health outcome data. So those are sort of the main tenets of why we were able to set up this randomized control trial. Effectively, what happens at the 9 acute care hospitals where the software is implemented is, once you record an adverse drug event that meets criteria for enrollment into the randomized trial, the software actually randomizes the patient in the background and blinds the frontline care providers to information flow or not. So that's a little bit around the randomized control trial and why we were able to launch it. We actually tried to convince ministry to allow us to launch a third randomized control trial using the exact same platform. And they said, I think you've got enough here. So we'll see if we can leverage ActionADE to actually do more randomized control trials. What's currently happening, and this is still a request to Health Canada, as you know, a new law came into effect called Vanessa's Law in December of 2019. In December of 2019, it became mandatory. It had been a law that had been in the making for quite some time, that received royal assent in about 5 years earlier. And what Health Canada would very much like to do is increase reporting of adverse drug reactions from frontline clinicians. As you may know, in British Columbia, acute care hospitals, they have to comply with Vanessa's Law. They have to report diagnosed adverse drug reactions that lead to a hospital admissions or are life-threatening or cause death. They have to report them to Health Canada. We did an evaluation and showed that reporting rates are exceedingly low. And what happens is there's a disconnect between the individuals who diagnose and hold the information, people like myself, maybe people like Tom when he's on the internal medicine wards, and the actual reporting interfaces that are so cumbersome to use that we generally just don't have the time to actually report. And there's also a disconnect between the fact that as a clinician, my obligation is to the patient in front of me, as opposed to the data that get generated and used in the background for science. And so, of course, bridging that gap hinges on making sure we really have usable interfaces that are accessible to people like myself and the clinicians, so that the information can really flow. And what we've always sort of said, we wrote an editorial on this in CMAJ, we should be really deriving those data as a byproduct of safer care delivery. I don't know a single clinician who does not want to provide safer care. So I just literally was on shift on Monday. I saw a 44-year-old who had 2 episodes, she had 2 cardiac arrests while on methadone, and is now on a different opioid replacement agent. And so this is exactly the type of report that I now put into ActionADE, because I really want to be certain that that community pharmacist knows that that event occurred and had a life-threatening implication for that patient. So this would be not a patient we would randomize. This patient would be excluded. The information would just flow to PharmaNet. But what we are doing right now is we're in conversations with Health Canada, trying to see whether or not we could implement more broadly. There's quite a bit of interest in implementing this software more broadly provincially, just because it makes the reporting of adverse drug reactions and other types of adverse drug events so much more user-friendly. And what we're trying to do with Health Canada is see if we can actually report directly from ActionADE to fulfill the reporting requirements with Health Canada. That's a long-winded way of telling you that we're working on basically just expanding the program and continuing on. Why don't I leave it there, and I'll just take questions, and I'm happy if you want me to jump back or talk about anything else. I'm completely fine with that.
Corinne, it's Aaron. Thank you so much. What a wonderful presentation. And you have certainly been busy over the years. I followed you and your work, and it's so nice to see the progress you've made. I'm going to start with a question, and then I'll refer to the chat and relay the questions that audience members have sent in. So my question to you is, if a clinician sees the adverse drug event report, we assume they know what to do with that information, and then they behave appropriately. And I bring that up because we were talking about prescribing audit and feedback. And one of our colleagues said that you can give prescribers information about how their prescribing is evidence-based or not, but they don't always know what to do, what the most appropriate next step is. So sometimes the effectiveness of that audit and feedback is minimal. Do you see that as being a problem here, that if you see that adverse drug event report, that people might not make the appropriate decision as the next step?
Absolutely. So one of the things that we're doing, and I'm sorry I don't have more detailed slides about the RCT. I have to fully disclose that I thought my presentation was tomorrow, so I was going to generate those slides tonight. So I apologize, Tom. I can see your comment. Absolutely. So what we're doing on the evaluation end is we're actually pulling data from PharmaNet that's actually not part of the regular suite of data that you can actually normally pull from POP data. And what we designed with the Ministry of Health is we actually designed intervention codes. So let me try to go back and explain a little bit what happens. And what I'm going to do is I'm just going to quickly stop sharing so that I can just pull back my okay. Can you guys see my screen again with just the report that I generated while I was speaking?
Yes, we can. Yes.
Okay. So these are just reports I've generated in the context of presentations. All right. So, oh, this was from early COVID when we were seeing patients on hydroxychloroquine in the eMERGE, and then they were also on azithromycin, and there's a bunch of long QT syndromes out there, drug-induced. So what'll happen is once so reporting an ADR or non-adherence or another type of dosing problem is literally as easy as I have just shown you in the minute that I just showed you. And I can actually do it in a minute while I'm in the clinical care environment. Once I hit that save button, we are directly integrated with PharmaNet. So we have used space in the PharmaNet is just a conglomeration of 8 different databases, federated databases managed by McKesson. And so what happens is there is space in their databases that we have sort of co-opted, and we were able to show them in 10,000 patients that had about 2,000 ADRs that none of their adverse drug reactions fields were being populated with useful information. 0 of over 2,000 adverse drug reactions were actually in there that we had found. And so they said, okay, fine, since it's free text and nobody's using it, we're going to allow you to use the 96 bits. And then we're also going to allow you to use a field in PharmaNet that's called clinical conditions that's also rarely used. And then what we did is we actually mapped the information that is contained, the 5 key data elements. We call them our minimum required data set. The way we arrived at the minimum required data set is we took all these concepts from all of these systematic reviews and all these reporting systems, and we basically bought the pharmacist lunch and we said, okay, here's a whole bunch of concepts. If you have to make a clinical decision, which ones do you absolutely need? Rank order them. You need the drug, you need the event, you might need the symptom, you need something about causality. It's pretty much what they told us. So these once we had done the data standards work in terms of how to bridge the clinical thinking with the documentation, we basically mapped every single one of those 5 concepts to space in PharmaNet. And then what we did is we had to have our software meet PharmaNet compliance standards. And effectively that work was complete on December 7th of 2020. That's when the first ADR report from our system actually crossed over and actually got stored in the PharmaNet database. So now that those 5 data elements are in the PharmaNet database, we've sort of achieved the communication gap that we're trying to test. So now that we've launched the randomized control trial, we built a randomization function into our front end of our ActionADE software. So once I enter the patient's PHN, maybe I'll just go back and just show you, let me just go back. I don't want to log out. May actually be quicker for me to just quickly log on again. Here we go. So the minute I add a new patient here and I put in the patient's PHN, it starts stratifying the patient by age and by site. I don't know if you realize, but at the very beginning, I actually put in that I work at VCH. So those are the 2 first ways in which the software stratifies the patient. And as soon as I determine the type of ADE that I'm going to document, we'll actually stratify the patient into one of our 2 randomized control trials, either the adverse drug reaction randomized control trial or the non-adherence trial. And the minute I hit the save button on the three types of, let me just go back in here, and why don't I just call this a gastrointestinal hemorrhage test, gastrointestinal. Here we go. I'm just going to pick this. Ignore the fact that it's chronic. You can see here I've ticked the medication. So it knows that it's an adverse drug event to aspirin, or I think that is. It knows the type of type of event it is. It's mapped to MEDRA terminology, which maps to an ICD-10. There's a time associated with that. I can or cannot enter treatments if I want. I can skip that. And then the minute that I have finished what I have done with this patient and the likelihood, if the 5 data elements that I have entered, if that meets the RCT requirements, the patient will be randomized. And then and then what happens is the minute I hit the save button, the information either goes into PharmaNet, and then it gets transmitted to community pharmacy software. So the minute a community pharmacist pulls up this patient, and I picked a bad medication because aspirin is usually not prescribed, but imagine this were prescribed medication. The minute the patient goes to fill their next hydrochlorothiazide prescription, or they go to pick it up, the system will generate a class level alert that tells them about this adverse drug event. And when that class level alert happens, so it's specific to the medication and it's specific to the patient, it's not a generic alert, the pharmacist has to acknowledge that and either override it and give the system a reason for the override. Those are called sort of intervention codes, or it can actually tell the system, you know what, I think this is baloney. I think you guys made an error. I'm just going to override and dispense. And so the way we are trying to understand the behavior is we're pulling all those intervention codes on the pharmacy end. And that's part of our process evaluation to understand whether we've calibrated the sensitivity and the specificity of these alerts sufficiently specific that we don't end up with alert fatigue.
Okay, thank you. Another question. I'm wondering if this integration system only includes ADEs in hospitalized patients. Serious non-urgent ADEs occur in outpatient care and can lead to hospitalization.
So it can be used anywhere in the system. Right now, the back end is with Vancouver Coastal, and it's part of the KDC data holding. So it's considered part of the health authority data. It could be used anywhere. You could, with the appropriate login credentials, you could log into this software anywhere. The reason why we launched the randomized control trial out of emergency departments and acute care hospitals is because we're trying to get a signal to noise ratio. And if we were to randomize patients with non-serious adverse drug events first, we were less likely to be able to show that there was any difference in patient outcomes. We were also a bit worried that if we started with non-serious adverse drug events, we may actually, people may be more likely to redispense the culprit drug as well. So I think, the plan is, let's see if it works in an acute care setting with serious ADRs, and then let's span out from there.
Okay, thank you. Tom is asking about correcting something that you've entered. So if you've incorrectly determined something is due to this particular drug and you learn later, can you go back and fix that?
That is one of the most important features. It's a fantastic question. And one of the reasons why pharmacists don't like writing into PharmaNet from the community pharmacy using the existing fields, because they can't update the information. And you and I know that patients change over time. And so what you can do here now, I reported this months ago in this, I can go in and I can modify this report. And what I can say is, you know what? I'm going to go here and I'm going to actually refute this diagnosis because, let's say an alternative diagnosis was made for patients with penicillin allergy. A lot of times, don't be too shocked, but when patients come in septic, sometimes we just re-expose the patient without really having realized that the patient was allergic. And in the vast majority of cases, the patient actually was not allergic, or the patient could have been allergy testing. So once I hit the OK button, just again, this is all a mock-up case, what'll happen once I refute this and I save this, it actually crosses it out in the system. And that refuted event, it will write over the old event in PharmaNet. So you can absolutely, so this is one of the reasons here when I used the interface, I deliberately put in possible. So a lot of our, particularly when we're seeing delirious patients, medications are possible. We often hold them. And then what we hope is that a pharmacist up on the wards, particularly now that we're implemented and more pharmacists are using it, that they can update these events.
Fantastic. So the other question is about the occurrence of high or low dose problems in repeat events. Can you elaborate on this as a cause?
Yeah, so let me see. I'm just going to see if I actually have that slide. I apologize. I skipped over some. So they are common. The dosing issues are common. Dosing issues are often a little bit subjective. And it's often not so clear, you know, what patient X needs. And so that's one issue to just make sure we're aware of when we talk about dosing problems. The other thing to just remember is that adverse drug reactions in high dose, you know, there's a bit of variation in how that gets documented. We try not to get too fussed about that differentiation. So in the randomized control trial, adverse drug reaction in high dose is actually lumped up and gets stratified into the same category. The other one that often is part of this is drug interactions. The drug interaction will often manifest as an adverse reaction to one of the drugs. And so we see a fair bit of variability in there. As you can see, if you combine high and low dose together, you see that in this, they comprised about 20% of the events. I don't have the data on repeat adverse drug events, but it roughly came out in the same rank order.
Okay.
So the big categories are adverse drug reactions, non-adherence, dosing problems, and then it gets much less common.
Okay, thank you. Someone's asking if there's a plan to include the data generated from this project to be available to other researchers.
Yeah, so we mapped everything. So so the way we've designed everything, this will be included into the administrative data sets. That's always been the vision. So a lot of our work has been around data standards. One of the things that we found in our data work is for clinicians, it's much easier. Clinicians don't like ICD-10 or 11 codes that are going to be coming. What's much easier for frontline clinicians to use, in particular pharmacists, is to use a data dictionary called MEDRA. And it's a free terminology that's used all over Europe. There's a mapping there's mapping from MEDRA terminology into the ICD-10 coding system. And so I don't know where ministry is at, but the vision would be for all of these diagnostic codes to end up in the administrative data sets.
Excellent. So a couple things, maybe just for my clarification, the person that commented on outpatient adverse drug events was also interested in serious outpatient adverse events. And I guess that's potentially the next iteration of this project.
Absolutely. So rather than thinking of it, we don't really think of it as an outpatient or an inpatient thing. So this is a web-based platform. Mm-hmm. You could access it from anywhere, and it really wouldn't matter to us where the provider is. I think long-term care could really use this as well because they see a lot of adverse drug events in there. The way seriousness and severity was a very difficult concept for us to tease apart and for clinicians to tease apart. And let me just add another ADE and just show you. It actually, let me just show you in here. I apologize. So I didn't, here we go. Here we go. This is what the ADE resulted in. Emergency visit or hospitalization is what made it into kind of the final 5. We don't per se have a tab that says serious or non-serious, but what we've mapped this to is the Health Canada requirements. Let me see if I can show this to you again, and I'm just going to show you that tab. Here we go. All right, we'll just go with the same one. So as I move forward in my reporting, this is really very closely related to seriousness and severity, but not quite the same thing. And it's basically the outcome of the ADE. So by mapping it directly to the outcomes that Health Canada is collecting data on to categorize the ADRs that they're collecting data on, it's much easier for us to become compliant with Health Canada reporting requirements. The reason why we didn't put in seriousness, severity, those are very, very subjective, and different types of physicians generally would report those in very different ways. I hope I've answered your question a little bit as to why it didn't make it into the final 5.
Okay. And there's 2 related questions. It involves who controls the report if there's people who disagree. So I enter the report, you look at it, and you refute my judgment.
Mm-hmm.
Who wins?
The last person who entered data.
Okay. But then
so
I could go in and rebut.
Me, you win. So the idea here, that's a great point, because 2 people can disagree. So what we encourage people to use is we really encourage people to use the full range of causality. And if there's one thing that I've learned is causality is often not that certain. There's often a lot of uncertainty in medicine. And like, you know, we had one case in one of our case series, we were sure it was an ADR to an anti-inflammatory, and the biopsy ended up coming back, you know, as gastric adeno-CA. So those events really just happen. So that's why the ability to refute or change the likelihood of an adverse drug event is so important, and to have that updated in the PharmaNet database is really important. What I didn't show you is another functionality, which is, for example, you can report a clinical condition like long QT syndrome, and you can actually report the QTC, and you can write into there, you know, the conditions that the patient, you know, maybe the patient had a potassium of 2.5 at that time. So you can put additional information in here, Erin, if you and I were to disagree. The disadvantages right now, because of the limitations of the space in PharmaNet, is the annotation doesn't make it into PharmaNet. We can't cross it over the bridge to the community pharmacist yet.
Okay,
the way ministry really views this as a pilot project. So we're hoping to collect feedback and then bring that back for the next iteration of PharmaNet for implementation.
Okay, there's a person from the island that's wanting access to this, but we don't want to share all our good stuff with people on the island. So that's not a possibility, right?
It will be. Oh, hi, Mohammed. I just saw a chat from you there. So right now, this is really, the data are being put on the VCH Health Authority data servers. We are absolutely happy to work with other health authorities. I know there's interest from ministry in pushing this out provincially. This is where my role as a scientist is a little bit limited. I don't work for health authorities, and we need that request to come from the health authorities. We also need that upfront investment in project management, in making sure all the privacy is worked out, making sure that where for example, island health data would be stored would be appropriate. But to implement in a new health authority would probably not be that much work, because we've already done all the integration work with the Ministry of Health, which I think that was really, in my mind, that was the largest, all that integration work on data standards and making sure that we're compliant with the PharmaNet legislation. That was a huge piece of work. So whoever you are welcome to email me, and I'll just put my email in the chat.
Great, thanks, Corinne. We have a couple of minutes, so I just want to say something before I give you the last word. Just a reminder to people to complete the evaluations when they're emailed to you. We use the information to try to improve on our education deliverables. And if you do fill out the evaluation, you'll receive a continuing education certificate. And Corinne, one last question for you as the last word. Could you comment on what is the funnest part of being an ActionADE researcher?
Well, I think it's just having that contact with the pharmacists. And, we did actually focus groups with physicians. So I think it was just really nice to really have contact with people who were interested in helping us move forward. I think that was really perhaps the funnest part, and just mulling over these ideas. I think that was perhaps the most rewarding part. And then I think what was really fun was when they would then see the next iteration of the software, some of them could then see how we had implemented their suggestions. And I think that really helped with, I think so many times systems are imposed on us and we sort of try to deal with what we've been given. And I'm not trying to complain at all. These systems are so difficult to implement. But this was a different kind of work where we sort of said to clinicians, okay, help us out here. You can actually control in part what's going to go in. And so I think that was the funnest part.
Fantastic. You're amazing. Your work is amazing. We're so lucky to have had you present at the webinar. Thanks so much. And thanks to everyone attended. I'll let you get back to your day. Have a good afternoon, everyone. Take care.
Thanks for having me.